thank you everybody for joining us today for session 3 of our Navigating ALS series. It's going to be on employment and insurance. And just a brief disclaimer that Rebecca is going to be presenting on some general facts about kind of this arena, but there's always different nuances about people's individual situations. So if you do want to talk through your situation specifically and your questions aren't answered through this presentation, then we can schedule a time to speak with you one-on-one. So just a reminder that we're going to keep everybody on mute throughout the presentation. If you do have questions, please use the chat box. It's at typically at the bottom of your screen. If you'll move your cursor around, you'll see the chat feature pop up. So you can enter your questions at any time there, and we'll be fielding those after the presentation. We are recording this presentation, so we will be emailing out the recording after this is finished. And so if you want to reference this at a later time, you can do so at that point. Well, again, thank you guys for joining us. We're excited to have Rebecca Axline with us, but before we hand it over to her, we want to pass it on to Linda.
Hi, hello everybody. I would like to just give you a brief overview of what the ALS Association and how we can help you with your journey. The association strives to create a world without ALS. Everything that we do can be traced back to the vision of no longer hearing of people being diagnosed with ALS. We want to discover treatment, a cure for ALS, and to serve, advocate, and empower people affected by ALS to live their life to the fullest. Next slide. The roles of Steve, Jennifer, and Jordan and myself are to help you meet the variety of needs, both tangible and emotional. We want to give you information, but we also want to give you hope. We want to inform you of your options and help you get connected to resources that may benefit you in your journey. We want to empower you so you are able to make informed decisions. We want to give you information on managing the disease and a general overview of the progression, because we have found that no two people are the same and the progression of ALS can be unpredictable at times. Next, we have our guest speaker, Rebecca. She has over 40 years of clinical and management experience in a variety of settings, including medical center, active duty military bases, VA centers, employee assistance, hospice, and school districts. Her role since 2006 has been to develop an outpatient social work at Houston Methodist Neurological Institute. She provides program development, clinical intervention with focus of supporting patients and family members cope with the stress of the diagnosis and treatment of neurological disorders. She is part of the ALS Team Hope and NAS National Alzheimer's Center. And now I'm going to hand it over to Rebecca.
Good afternoon. So glad to be here and to share with you some of the things that I've encountered and learned over the past 40 years of social work and 16 years on this ALS Team Hope at Houston Methodist. And I hope, if you don't mind, I am going to read from my notes, because if I get too enthusiastic, I talk too fast and I might miss some of the important stuff that I've written down. So let's dive into the topics. As Steve mentioned, I think it's important to remember that each person's journey and experience is unique. And while I'm going to give you broad examples and suggestions and tips, they may not fit into your world exactly. Please type any questions you have into the chat and definitely follow up with a social worker on your team. The social workers are here to help you navigate and gain information, because we know that information is power. And each of you have agency to make decisions and to have your family help you make decisions about your health care. My purpose is to lessen the overwhelming stress of change, of decisions, and barriers to care. It is not my role to make decisions for you. In fact, that's unethical. But I will make suggestions and give you some examples. So one last thing I wanted to mention, while again, I'm talking about broad overviews of programs, please understand while these may seem complicated, if you remember back to the first time you ever used a computer or an iPhone or an Android, remember how overwhelming that seemed? We learn by asking questions, by exploring resources, and trying not to be too overwhelmed or to shame ourselves into thinking that we are somehow not intelligent enough to understand. It's really valuable for you to use things like Medicare.gov, some of the Google things to look at the resources you're looking for. The ALS Association has incredible fact sheets and information, so explore what you can to understand your unique needs. So here we go. How do I decide about work? So what I usually tell the folks that I meet is I think it's a very personal decision. And I think to consider things like, does your current symptoms, the current symptoms that you have, do they affect your ability to work? Do you want to work? Is it providing you purpose? My feeling is that all humans, we need purpose, we need value in life. And if a big part of your life has been work and you find a great deal of purpose and satisfaction, then if you're going to stop working, it's really important to consider what are you going to do to replace that kind of feeling and the feeling of being worthwhile. What is the cost benefit analysis of your continued employment? Does it hinder your ability to stay safe? Does it involve risk for falls? Is it overwhelmingly fatiguing? Does it affect, is your speech affected? You know, what is the cost benefit? Because to continue employment when it doesn't bring you satisfaction and it's causing risks may not be a good combination. I also think it's important to gather information about what you have at your particular work site. Do you have short and long-term disability? How supportive is your employer if you wanted some adaptations at work, the OSHA, ADA kind of requirements? Just think about how you would present the information if you were to stop working and what works for you. Most importantly, as I said before, the emotional aspects. I think it's important for the person diagnosed with ALS to make the decision about work, because you maintain power and agency over your own choices, rather than someone telling you that you have to stop working. You're making a decision to say, I could, but I'm making a decision not to because of these reasons. Part of the reason for that is also knowing what options you have to support your family and support yourself, and insurance is a big part of that. So let's talk about when to apply for Social Security disability. So navigating Social Security, that's a big piece. So let's talk about the 3 programs that Social Security has. The first one is what we call Social Security. It's what we all think we're going to use eventually when we decide to retire. We can take it early at age 62, or we can wait for our full benefits to kick in at 66, 67, depending on your year of birth. The second program is called SSI, and it's Supplemental Security Income. It's for people who were perhaps disabled as a child or unable to work, or maybe the kind of work they did was below poverty level, and they don't have it. It's based on your assets and your income. Supplemental Security Income, SSI. The third program is SSDI, Social Security Disability Income. And I want you to notice really quick the closeness between SSI and SSDI. Gets very confusing for people. SSDI is basically you're saying, I have to leave the workforce because of my diagnosis, because of my physical function, and so I'm asking to receive my Social Security at an earlier age. It's not based on income or assets. It's by receiving what you paid into the system, and it looks at the credits in the last 5 out of 10 years. So let's say you're in your 20s, late 20s, and you decide to leave the workforce to be a full-time parent. If you then become disabled before you've gone back to work, you may not be eligible for disability if you have been a stay-at-home parent for more than 5 years. So people really need to consider that when they think about the work credits that they have. When you're with a diagnosis of ALS, you have what we call presumptive disability. That means that you don't have to show people how many steps you can take. You don't have to see an outside doctor to look at your disability. Your diagnosis alone by a credible neurologist is all you need to apply for Social Security disability. And with all the advocacy that the ALS folks have done, at the same time that you receive Social Security disability, you're also eligible for Medicare. For the rest of the population, other than end-stage renal disease, you have to wait 24 months or 2 years before you're eligible for Medicare. So if I had a bad back and I had to stop working, I would have to wait 24 months from the time my disability started to when Medicare kicked in. For ALS, it starts at the same time. Now, previous to 2020, December 2020, there was a 5-month window that you had to wait from the time you stopped working till when Social Security disability started. As of December, that was waived. So at this point in time, the date of your diagnosis and the date you stop working, meaning going into the office, receiving a paycheck, that's what they consider gainful employment. That starts when you're eligible for Social Security disability and also eligible for Medicare. Caveat, during COVID and even up into this time, Social Security is a government entity and it isn't always as fast as we'd like it to be. So some people go online or start the application and they're frustrated because it doesn't turn around in a dime. And I get it, but it doesn't mean that you're not eligible. It just means you have to wait for the government to process and make you have or give you the benefits that you're eligible for. Another one tip, the reason I mentioned the SSI and SSDI, this just happened recently. When you apply for Social Security disability, by law, they're mandated to ask you about assets and income because they don't want anybody to fall through the cracks. And you might be eligible for SSI and SSDI, but they have to make sure that, so they ask you a few asset questions. You may get a letter in the mail that says you have been denied for SSI. Confuses people all the time because it's so close to SSDI. But make sure you look at that, because if it says you're denied for SSI, that just means you make too much money to be eligible for anything depending upon your income and assets. Okay, so a couple of tips about applying for Social Security disability. There was a time when you could go online or call by phone. You still can call by phone, but they really encourage people to go online and start the application online. If you do call the 1-800 number, a few tips that I give is if it's going to tell you there's 35 or 40 minutes to wait and it gives you a callback option, use it. It works. If you've already had some speech changes, please give permission for someone else to talk on your behalf. And also ask for the form that I often give my family members. It's called Patient Representative, and it's the HIPAA form specific to Social Security, because it then puts on your record that this person can now talk to you on your behalf. And when they call to see what the status is or to give some updated information, you don't have to go through the very frustrating process of trying to explain to them your name, your date of birth, your mother's maiden name, where you were born, with your speech changes. I also, with our folks that come to our clinic, with the doctor's permission, I give them a letter of diagnosis, and I include in there the coding that specifically talks about ALS and presumptive disability, because not that people need it in order to start the process, but it just educates the people that you're dealing with at Social Security about your particular diagnosis. Things have to be coded specifically for Medicare to kick in. And if they don't have that particular code, or they've never worked with somebody diagnosed with ALS before, they may not do it correctly. It hasn't happened recently, but we've had it happen in the past where it was coded incorrectly, and it just took a lot of time and frustration for things to get coded correctly. So ask your team. I certainly have a template that I use, and if any of your social workers want to use my template, I'm welcome to share it with them. The other thing is, if you go on the phone or if you're talking to Social Security at any point in time and you get someone who is particularly having a bad day, they may be rude, they may be uncaring, be a little flippant. I think it's okay to fib a little bit and say somebody just came to the door and you'll have to call back, and call back at another time and wait until you get somebody who's very compassionate about it, because everybody can have a bad day at the office, but it's your emotional energy is worth making sure that you're talking to someone who can be really helpful. I do say to avoid going to your local Social Security office unless you have an appointment. There's no reason for you to do that. If you go online or you call on the phone, you will get an appointment and then you go in. It's a whole different process than if you just go in as a walk-in. Okay, that's a lot, but I'm going to keep going. Let's see what the next slide says. I think we're talking about Medicare options. Okay, this is a class in itself, but we'll do our best to cover the bases. And as Steve said, if there's particular questions you have, contact your social worker, email. We can hopefully answer some of those questions. Once you have been awarded Social Security Disability and Medicare, you now have an initial 7 months of what we call an initial enrollment period to pick the programs you want. That being said, I think it's really important to think about during those 7 months what you want happen, because what people don't tell you is that when the Affordable Care Act came out and the pre-existing clause for not being nobody can deny insurance because of a pre-existing condition, that still applies. But I'll make a quick example. If I sign up for Medicare and during my 7-month enrollment, I pick a Medicare Advantage plan, and then 2 years later I say, I don't like this, I want to go back to traditional Medicare. At that point in time, you're eligible for traditional Medicare, but any supplemental supplemental insurance you apply for is now underwritten. And that means pre-existing does exist. So they can either deny or they can charge you an enormous amount of money for it. When you first sign up for Medicare during that 7 month, they can't do that. But at some point, if you go on one plan and want to jump back, then you can be penalized. I know that's a lot of information, but I just think that 7 months is a good time to think about what's going to be in your best interest. So traditional Medicare covers 80%. And that means anytime you see the doctor, anytime you're hospitalized, you have a 20% bill that you're still obligated to pay. So that's why they have what they call Medigap options. And Medigap is basically paying for 20% that the Medicare doesn't pay. When you go to Medicare.gov, you can go in there, put your zip code in, or even your Social Security number, your Medicare number, and they can go through and give you a list of Medigap options that might be available to you. We also call them supplemental insurance. It's the same word. They have a life of their own. There's Plan A, Plan B, Plan C, some of the ones that have been discontinued. If you've been around a lot of people with Medicare, you probably know that the most comprehensive coverage for supplemental plans are either Plan F or Plan G. And most recently, they phased out Plan F. So the majority of people that I meet that have traditional Medicare and a Medigap supplemental policy have a Plan G. What they don't necessarily tell you is that those plans are available to you over 65, but under 65, the state that you live in, and Texas is one of those, may limit the plans that they offer you. And in Texas, they are only obligated to offer you Plan A as in Apple. It's not a bad plan, but it's not as comprehensive and it can be expensive. So a lot of times when I'm counseling individuals under the age of 65 who've been diagnosed and are going on Medicare, I suggest that they consider the Medicare Advantage plans because they may be a better coverage than traditional Medicare because you can't get the supplemental policy that you can when you're over the age of 65. I'll just leave it at that. You also need to sign up if you're on original Medicare and a supplemental policy. Then you also need to look at Part D, the prescription coverage for options. And some people tell me, oh, well, I didn't sign up for Part D because I didn't have any medications I was using. And what I remind them is when you initially go on Medicare, if you don't sign up for a Part D and you decide a year or two down the road that you want to sign up for it, you're going to be penalized they will add on an additional fee because you didn't sign up to begin with. So when you're signing up for original Medicare, if you go on Medicare with a supplemental policy, pick a Part D, just get the cheapest plan there is, and know that you've got a plan that you're not going to use a whole lot, but that in the future you won't be penalized if you have to then add on prescription coverage for that. Now, that being said, Medicare Part C is what we also know as Medicare Advantage plans. Now, the philosophy for this was when Medicare was started, the private insurance corporation said, you know, you can't have a monopoly and everybody go on a government plan. You have to let us be part of the plan to market these people to give them another option. So Blue Cross, Cigna, United Healthcare, Aetna, all the big players develop their own Medicare Advantage plans, and you see them every year on those commercials that we all watch, especially in the fall. They can be, as I said, they can be good plans, especially for people under 65, if everyone that you're seeing is in network with that Medicare Advantage plan you're on. I've really been happy in the last several years when the PPO plans came out, because when Medicare Advantage plans were available years ago, all of them were what we call HMOs, or health maintenance organizations. And so every time you wanted to see a doctor or see somebody new, you had to get a referral from your primary care doctor. He or she became the gatekeeper. With the PPO plans, as long as everybody's in network, then you can go to whoever you want, and they can be really valuable. That being said, there's a whole lot of them out there, and it's really important for you to do your research to think about what kind of coverage is. Sometimes there's high premiums and then very little copays. Sometimes there's very low premiums and a lot of copays. So you have to decide what works for you and what works with the kind of docs that you are in network with back home, as well as with your ALS specialist. You can change during open enrollment, and also Medicare Advantage plans has a separate enrollment. In fact, it's going on right now. So this month until March 31st, if you're on a Medicare Advantage plan and want to switch to another Medicare Advantage plan, you might be able to do that now. You can't switch back to original Medicare now. You have to do that during open enrollment. So it's important to know when your open enrollments are specific for each plan that you have. This could be a whole nother subject, but the other thing I do, because I'm working for particular individuals in the team that I'm on, is we talk about specifics of their particular situation. For example, if you're going on disability and you're going on Medicare and your spouse is still employed and they have pretty good insurance, and maybe you're going to go on their insurance primary, you might not need to go on a Medicare Advantage. You might be okay to just use their insurance as primary and have traditional Medicare as your secondary, and you'll still be insured. If your spouse is retired and they're on Medicare, it's going to be a little different, because then your Medicare would be primary, and then you still need a supplement. But if your spouse has a retirement supplement, like worked for the government or worked for someone that has retiree benefits, you may be able to, again, only take original Medicare and have some coverage through their benefits. So you see how there's general principles, and then there's other options. I see a quick question in the chat. I'm just going to go ahead and address because we're right on that. Medicare is primary if it's your insurance, you're not on your spouse's insurance, or your spouse is retired. As long as they work for an employer with more than 100 employees, if you were on their insurance would be primary and Medicare would be secondary. So that makes sense. COBRA is different. We don't encourage people to go on COBRA because sometimes you can be penalized if you don't go directly on Medicare. But again, those are specifics that maybe we can talk about at another time, because that can go down a wormhole specific to COBRA. That's its own piece. So let's go ahead and move on to the Medicaid, because we got some other things to talk about.
Okay, can I
Medicaid
just-
is I'm sorry.
Hi, it's
Yeah.
Jennifer. Can I just slip in one other question?
Sure.
It was right ahead, and it said, is there any benefit difference between traditional Medicare versus disability Medicare?
No, Medicare is Medicare. There isn't. The term disability Medicare to me just means that you've gone on it at an earlier age than you would normally go on it. The caveat is back to what I mentioned about the Medigap supplemental policies. If you're on disability Medicare, that almost insinuates that you're younger than age 65. So that means that you may need to look at the options you have for supplements. Does that make sense?
Yeah, it does.
Yeah.
Thank you so much.
Okay, sure. So going on to Medicare, Medicaid is a federal program, but it's run by the states. Several years ago, when the Affordable Care Act became into fruition, the states were offered to expand Medicaid. Some states did, many states did not. Texas did not. Therefore, if you've heard from well-meaning friends or family members across the country, especially in California, New York, some other states, even New Mexico, they will say, well, my folks are on Medicaid. Have you looked into Medicaid? People ask me every week, how can we get on Medicaid in Texas? In Texas, traditional Medicaid, you have to make less than, I think it just went up this year to $841 a month to be on traditional Medicaid. That's pretty low. So most people that I know will not qualify for that. So Medicaid itself and traditional Medicaid and SSI is also depending on your assets. You have to have less than $2,000 in a savings or checking account. You can't have one car, you can't have one home. You can't have more than $2,000 face value in a burial a plan as well. So Medicaid itself is very limited in Texas. There is one other program that we often recommend to families to consider, which is called Star Plus Waiver. This was a program that was developed for people that were having to consider going into a nursing home, a skilled nursing facility, and going on long-term care Medicaid, which you can sometimes be eligible for without being eligible for traditional Medicaid. So Star Plus Waiver said that if you have an income level that's still restrictive, but you were going to have to go ahead and go into a nursing home where the state was going to end up paying for the nursing home, it might save us money to provide you some provider care in the home. So they will offer some caregiver custodial care in the home, but you have to apply for the program. Sometimes there's waiting lists based on your county that you live in, and you have to make sure that you qualify as well. There's a few other programs. I don't know if they're on this slide or not. I don't want to jump forward, but QMB is something that some people are on. It's called Qualified Medical Beneficiary, Medicare Beneficiary. If you have an income less than $1,100 a month, that sometimes they'll help you with supplemental fees and they'll help you with prescription costs. So you always want to see if there's other help that you can get. But I just want people to be realistic about what they can get in the state of Texas. We often get asked, can my spouse be paid to take care of me at home? And in some states, they are eligible to do that, but Texas is not one of them. And it's very limited. I won't say it never happens, but it's very limited. So it's important to ask your social worker for some of the resources to look at that, to see if you're eligible. Okay. We often encourage you to discuss with team member, social worker, and elder attorney who might be exploring the options, because elder attorneys can be really helpful in helping you differentiate yours and your spouse's income so that you might be eligible for things that you wouldn't be jointly, especially if you're looking at long-term care. Let me mention one thing that's often asked. Does Medicare pay for care in the home? Again, this is a topic that we could have a whole nother talk on. But Medicare and most private insurances will pay for what we call skilled care. That's a nurse, occupational therapist, physical therapist, somebody that has an actual license, okay? Doesn't mean it isn't good care, but skilled care is someone with a license. When you have home care by skilled folks, let's say you have skilled nursing come in or PTs coming in to teach you how to use a Hoyer lift, most home care agencies will offer you 1 to 2 visits a week of what we call a custodial care. It's done by a certified nursing assistant. They're still wonderfully skilled people, but they have a certification, not a license. It won't pay for 24/7 kind of custodial care. Some of the Medicare Advantage plans you can Google and they have a clause that say their insurance that they pay for X number of attendant hours per month. But you don't do this through a prescription from your doctor's office. You have to call your insurance and ask them how you make that happen. And many times in Texas, it's not going to be a plan because it may tie into these Medicaid options. But it's worth talking to. So if your Medicare Advantage plan says to you, you have 32 hours a month of attendant services available to you, then it's important for you to find out to them how to access that. It's not by a prescription, because the prescriptions the doctors get are for skilled home care done by a home health agency, okay? So let's move on to TRS. Do I need to do that? Yeah, there we go. Whoops, okay, I missed the slide. See, we'll just review it real quick, but it's again, okay, we did this already. Can we move forward? There we go. And here's a couple of websites, since you'll have access to this, that you can Google to look at your own eligibility test. So you can see what you might be eligible for in the state of Texas. Okay. So let's navigate teachers' retirement system. Social Security, unlike Social Security, TRS is a retirement plan, like Social Security. Instead of paying dollars into Social Security, you've been paying dollars into the Texas Teachers Retirement System. Other retirement systems you may be familiar with are railroad benefits, the older federal government program called CRCS, which has now been phased out by what we call FERS, F-E-R-S, State of Texas Retirement. So it's really important to see, what have I been paying into and what am I eligible for? If you can apply for TRS disability retirement to make sure you have the appropriate coverage. Usually for TRS, you have to have 10 years of service. You can get a small stipend of retirement under 10 years, but it's very limited. I want to say it's like $150 a month. Don't quote me because I haven't looked at the up-to-date of this year's, but TRS has its own website that tells you how to walk through a filing for teachers' retirement system. It's really important, even if you're eligible for straight retirement, to explore with them if there's any benefits to you applying for disability retirement versus regular retirement. I don't know it well enough to tell you that it is, but I think it's worth checking into, even if you've worked for the teachers' retirement system for over 15 years, ask. You still might be eligible for Social Security for quarters that you've paid in earlier in your life, but you can't apply for Social Security disability if the last 5 out of 10 years you've been working as a teacher in the TRS system. You'd have to wait till after age 66, 67, whatever your full age is, to then look and see if you're eligible for any regular Social Security benefits or Social Security benefits on behalf of your spouse. So it's important to understand that if you're under age 65 and you've been paying into TRS, number one, if it's been the last 5 out of 10 years and you have over 10 years service, great, you can apply for that retirement system. They will normally give you an option to buy into their insurance. And what they've normally been using is a Medicare Advantage plan, but it's specific to their their program. And so it's been pretty, most people have been pretty pleased with it. They used to use a Humana plan, and now in the last year or two, they've been using United Healthcare. So they negotiate with the different insurers to get a good plan for their beneficiaries. If you've also want to look at traditional Medicare, you're really not eligible for that at this point, because again, you've been paying into TRS, not into Social Security. I hope that it is understandably. Anyway, let's move on to veterans benefits. Okay. Back in the Persian Gulf era, they saw an increased incidence of Persian Gulf veterans who were getting diagnosed with ALS. So they did a research study, and they came out with a 6% increase in people from the Persian Gulf era that were diagnosed with ALS. So in 2006, they did that procedure in 2006. In 2008, they deemed ALS to be a service-connected disease. And if you're not a military veteran, briefly, a service-connected disease means they feel a connection to your disease to the time you were in service, and they're willing to give you something from 0 to 100% rating about how much it was connected to your time in service. And 0% to 100% is the amount of money you get, and also the amount of care that you can get through the VA hospital. When they decided that ALS was a service-connected disability, they also opened it to all campaigns. So anyone who's a veteran, World War II and up, World War I, if you're still living, and is diagnosed with ALS or PLS or PMA within the spectrum, and they've had 90 consecutive days of active duty, meaning you have a DD-214, which is your discharge papers, then you're eligible to file for service-connected disability for the diagnosis of ALS. The Paralyzed Veterans of America have been, most of our folks have worked with them. They've kind of taken on ALS, but other veterans organizations certainly are available as well. The Disabled American Veterans, Texas Veterans Commission. We have a gentleman from the Paralyzed Veterans of America who works with all of the folks at our clinic. And what he does is request permission from them to represent him to the rating board. He gets the information, and he or she makes it very easy for these veterans to receive benefits. They don't have quite the red tape that a lot of other veterans do going through this process. In addition, if the disease progresses and there's increased loss, they can request increased benefits for them. They have 2 levels of benefits. 100% service-connected benefits right now is right around $3,000 a month, and that's non-taxable income, in addition receiving treatment from the VA, in addition to treatment from our clinics in your respective hospital settings. If you have an additional loss of some kind of function of a limb, it can go up to, I want to say 7,000 or 8,000, and the top level is of about 9,000 or 9,500. So it's a substantial amount of money that veterans are given to help them take care of themselves, take care of their families. In addition, there's a few other benefits, including a stipend for modifications to the home, a stipend to pay for a motorized wheelchair, and certainly survivor benefits. So it's really important to, if you are a veteran, to make sure that you connected with these resources to get your eligible benefits. As I tell people, it's not an entitlement. You served your country and you deserve every benefit that you're eligible for. Some people, excuse me, do come in that are maybe they've been on reserve duty, or they've been on the Texas Guard. Most of those people are not eligible for these benefits unless they've been activated. So let's say you were a veteran, you were in the National Guard back in the early 60s, and you were activated during the Cuban Missile Crisis. You still may be eligible as a veteran. So everything is a case-by-case basis. So we always ask our folks if they're a veteran, so we can explore what options they may be eligible for. Okay. Next. So long-term care insurance, I would be remiss if not to mention this, and our folks at the ALS Association are also very good at bringing this up. Many people do not have this benefit, but those people that do, it can be helpful for what we talked about before as custodial care. Long-term care insurance was something that was marketed years and years ago. Many people did not buy it. It was based on their age. And then some of the products now have a limited life. Some of them are lifetime maximum. Some of them have a certain number of days of care maximum. They have certain what we call walk-in benefits. So you have to pay for the first 6 months and then they start working. Everyone's different. They're all different products by different organizations. But if you have one, it's really worthwhile to pull out the paperwork and talk to the company and find out what it covers and how you might utilize it. It usually is based on the level of functioning. So many of them say you have to be impaired in 2 to 3 or 3 to 4 areas of functioning, mobility, ability to eat, all those kinds of things, different benefits. So like I said, every form is different. Some of them have home modification benefits, so it's worth exploring those. Some of them offer emergency alert systems. So again, if you're familiar with a product, if you think you have it, pull it out, contact the company to find out what particular information your insurance covers. Since we mentioned emergency alert systems, I think those are really beneficial. And even if they're not part of your insurance coverage, I think they're worth considering. Medic Alert, there are some programs, some Apple Watches have them now. They're all different shapes and sizes and prices. Some of them, like Philips Electronics, have different adaptations, especially if, let's say, your hands are involved and you can't push a button, or there's other ways that you need to use to activate the buttons, the system. Those are important to have. But especially if you're home alone a lot, it's really, really valuable information to have. One of the things that I mentioned the last time I did this talk as well is just some other things to look at in terms of benefits to help pay for care at home. Many people have life insurance policies, and oftentimes many people don't look to see if their term insurance is versus whole life. A term insurance, basically you pay into it and it has a benefit of paying at the time of yours or whoever's covering death. But whole life policy has an additional kind of savings account that goes along with it. And because of that particular aspect, if you're diagnosed with something that's considered a terminal disease, you can sometimes withdraw that money ahead of time. So let's say I have a whole life insurance policy for $100,000 and I'm diagnosed with ALS. If I document or get a letter from the doctor that says it's considered to be a terminal disease, then I may be able to pull out some of that money ahead of time to pay for my own care. Not everybody wants to do this, but I think it's a good resource to know about. And as much as you all know, because of how we believe about hope and ALS, and people are learning to live longer and longer with this disease, talking about a terminal disease is not always what I want to do with people. But I tell them I will give them what I usually call the doom and gloom letter if it gets them benefits that will help them. As much as I believe that people are living longer and longer with ALS, I also want you to have quality of life. So we try to, in our clinic, try to give you what will access you the most care options possible. Next. I think that's it. So I've talked a lot about a lot of things. I'm going to let Linda take over, and please, if there's additional questions in the chat, I'd be glad to handle them if I can.
Okay, so far we don't have any questions.
Sorry, Jennifer, I thought.
No, that's okay. Yeah, so far we don't have any questions. I just want to take this opportunity to thank you again, and again and again. Every time you present something, there's always more to learn. There's so much information, and it's just hard. It's hard to navigate. So thank you for offering your expertise. I just wanted to remind everybody that the presentation is being recorded and it will be emailed to those of you who registered. If you do have any additional questions that you haven't thought of, but you do later, please feel free to follow up with anyone on the team. Steve, me, Linda, and Jordan would be happy to get your questions answered for you to the best of our ability. Remember also to check out als.org for other offerings that we have, any webinars, workshops, things like that. And also you can find recordings of past things that we have done. I also too wanted to introduce again programs. This is our program director, Tanya Hitchman, and she's the one who brings our programs to you for youth and children, for the caregiver program. We're trying to offer many places that you guys can get plugged in so you can get connected and you can get as much information as you can, because like Rebecca said, information is power. And then we have Marshall Nelson, our very own Marshall Nelson. So he handles our equipment loan bank. In the ALS Association, we have, I like to call it everything from soup to nuts. So, you know, we could have small items, we can have large items of power wheelchairs and a bunch of stuff in between. You don't know what you don't know. And usually every challenge that people might have, there's a way to surmount it. And so Marshall's our guy. Of course, you can contact us as well. But if there's a way or a challenge or a need or something that you may have, let us help you. And so, yeah, Marshall's our man. Well, there we go. There's our contact information for all of us. Again, thank you for attending. Our next Navigating ALS series is on the multidisciplinary care approach, and that will be on April 11th. Many times people you meet will say, well, why do I have to go to clinic, or I don't want to go to clinic? And so we're going to give you the reasons why. Yeah, so please join us. I won't give you too much, so you'll come and join us on April 12th. And I think that's about it. Thank you again for attending, and we'll see you next time.